one minute per patient. Very simple. This is not patient one. This is patient one. This is patient one, 24 years old male, a couple of years ago. 3 previous episodes of severe, we call it secondary HLH. Post-hoc, the first and the second episodes met the ILA criteria for systemic JIA, but he had long-lasting, disease-free, therapy-free periods. Degranulation and perforation expression and cytotoxic assay are normal. Genetics was normal. So we don't know what this guy has. Essentially, wool genome so far, no good. May 26 is in very good condition, no fever, there's nothing there. All his cell counts are normal, accused ferritin reactants are negative, but his transaminases are in the range of thousands. GGT is increased, bilirubin is up, and there is high ferritin. We know what the guy has because he has had 2 previous episodes of HLH. So we do a liver biopsy. There is before initiation of glucocorticoids, there is significant inflammation with patchy hepatocellular hepatocytes necrosis. What really does make the difference is CD68, which are all over the place in the sinusoids. CD163 are there. There is hemophagocytosis in the liver, and I forgot the Cd8, but it's essentially Cd8 and very little CD4. Not in these things, but I can share with you whatever you want. This is all I have here.
That's exactly what Sabrina had. So very, very similar pathology. We did not see frank hemophagocytosis.
But this is glycophorin staining, so it's a bit more sensitive than just looking for hemophagocytosis. So I think I wouldn't have seen it if not for the glycophorin staining. And we looked at the expression of a number of genes. Actually, I forgot the latest picture we have, which is submitted. So we looked at the standard pro-inflammatory cytokines. The number in reds means that these genes IL-8 and IL-6 are downregulated compared to a control liver. The control liver is a patient with autoimmune hepatitis, known of the immune hepatitis, so it's an inflamed liver. But when we looked at the interferon gamma expression and the interferon gamma inducible genes, it's clearly significantly higher than the control. The patient was treated with high-dose glucocorticoid and cyclosporine and did well. Unfortunately, his transaminases are coming up again. So this is patient 2. This is a girl seen somewhere else at age 16 with onset of what they think, and I believe them, it's systemic GIA. I never saw the patient, complicated by MAS, good initial response to glucocorticoid and anakinra, high dose, but then she develops a normal liver function test in the absence of inflammation, in the absence of a flare. Ferritin, it's increasing again, so they did a biopsy. Here is the biopsy on glucocorticoids, high dose and anakinra. There is inflammation, not as strongly as the other one. And you see again CD68, CD163 positive cells in the liver, no hemophagocytosis. Again, did the same exercise with standard inflammatory cytokines compared to the liver.
Is it massive? It is massive, right? It's not protein.
It's mRNA expression. Yeah. It is, and again, the interferon gamma pathway is highly upregulated. Yep, hepatocellular necrosis. Oh, yeah. That's it. I know. We also have evidence of STAT1 phosphorylation in the livers, as well as measurable CXCL9 in the liver. I mean, I think we are starting to understand the biology. I think that these 2 patients, well, actually we have 4 now, submitted. It looks to me like, it appears to me like the conclusion is there are cases of, liver, I don't know how to call it, isolated, restricted, or predominantly liver HLH. I think some of the acute liver failure Scott was alluding to, they look like, because if I look at the histology of some patients that are published, they have very high level of Cd8 infiltrating cells. Some of them even mention high expression of interferon gamma. So it's...
Well, if you look in their blood, they have tons of CD25. And a few we've looked at have a lot of CD25. Ferritin's often normal.
All my patients have very high.
And the IPOL.
So I think this is again, acute liver failure is broad, but some of them are here, and they're very close. Now, these two patients, one has SGIA, the other one maybe has something that looks like SGIA. I'm not sure, but that's it.
I should have your biopsy sent to me today, okay? So probably tomorrow I'll give you. But the point is that what you have is identical.
One, that's what Dr. Romero said, that she's considering doing a second biopsy. She wanted to contact you. She said she was going to message you because it's going up again.
But yes, I wanted to show a couple of very old slides. Actually, I was hoping to get your slides, okay? But since I did not get those slides, I would like to show you a few figures from a very old paper published by Karin Wouters in 2005, I believe. Yes, exactly right. Right. Mhm. So this particular paper was published in 2005, and Karin described 5 patients in this paper who did look clinically like relatively mild macrophage activation syndrome. All had a bone marrow done, showed histiocytic expansion, but they did not see frank hemophagocytosis. But then the liver disease persisted, actually very similar to what you were just describing, and they proceeded with a liver biopsy in all of those 5 patients. And I don't understand what happened to the quality of these figures, but the point is that sort of here we are looking at a low level of magnification. We are looking at the portal periportal area. As you can see, sort of we have massive mononuclear cell infiltration in that area. Now, if you look at the high level of magnification, and again, that's Cd8 staining. So a couple of points here. So typically, macrophages, when they reside in liver, we call them Cupra cells. So these are Cupra cells, but we can call them macrophages. So typical Cupra cells are flat. So sort of they look like this cell in particular. So what we see in this particular clinical phenomenon, this histiocytes becomes very plump. They start looking very much similar to what we see in macrophage activation syndrome in the bone marrow. And again, in this example, many of those plump cells, in fact, are hemophagocytosing other blood marrow elements. So expansion, not just expansion, we see activation, and when I say activation, these cells become very, very plump, and then we start seeing frank hemophagocytosis. The other important thing that Karin did in this particular paper, so these are serial sections. So the next section was stained for pro-inflammatory cytokines, and she showed that in addition to being hemophagocytic, these macrophages also produce large amounts of pro-inflammatory cytokines, including TNF-alpha and IL-6. Another prominent cell population in that lesion was Cd8 cells, and now here we're looking at Cd8 staining, and again, serial sections. And the point is that sort of she showed that these Cd8 positive cells were also expressing huge amount of interferon gamma. So what you just saw, what Fabrizio just showed, right? He showed messenger RNA levels, right? So Karin in this particular paper did staining and showed that clearly the interferon gamma was increased at a protein level. And sort of what was, and she did not show that in the paper, but she mentioned that CD4 staining produced just a few cells. The other thing that was done in this study, they did massive evaluation for autoimmune hepatitis. They did lots of immunohistochemistry for various pathogens, and the infectious disease workup was completely negative there. Those 5 patients were actually very, very difficult. And in fact, if you look at the paper and look how they treated, they all received massive T-cell directed therapies. 2 of them received ATG. A couple of them were treated with, I believe, sirolimus or tacrolimus, in addition to cyclosporin, and I believe one of the patients received etoposide. One patient died. But the point is that that's what distinguishes, again, somebody brought up the idea of anakinra-induced liver injury, correct? And that's sort of a very, very challenging issue in those kids. And I can tell you that the anakinra-induced liver injury looks completely different. The histopathology looks very different. In fact, we have one patient who had 2 serial biopsies, and one was MAS, the other one was anakinra-induced liver injury. And sort of, if we if you're interested, we can actually discuss that later. Because Scott was the first who described actually this anakin-induced liver injury.
Is the anakin one like pretty bland?
Yeah, yeah. No cells.
I don't,
Yeah.
I don't have it. We just had, we compiled 3 cases of paradoxical hepatitis in patients who were responding to anakin.
So the only thing I have to say is that we tried very hard with several anti-interferon gamma antibodies,
Correct.
and it is really very difficult to just induce immunohistochemical states.
Correct. I have to say that Karine had an amazing pathologist here because we've tried the same thing in our center and we could not get those antibodies working. Ah. Oh.
I tried the same antibody, and clearly we're not good enough.
How about CXL9?
Very high. Well, I don't know about this study. I should have a look at CXL9.
That study, is that the study? No, it's the other one on the leaf node, which looked like a 10. They looked at CXL10, and it was very high.
But sort of now I have 3 patients with this pattern, and all of them have high CXCL9 levels. And then just to sort of to show that sort of this kind of CD8 predominance, that's one of actually patients with MAS, just to show the CD8 predominance in the infiltrate in the bone marrow. But that's not, and that's, by the way, the reason I'm showing that, because the patient that we are treating right now with emapalumab had exactly this kind of picture in the bone marrow with this sort of massive predominance of CD8 cells and histiocytic expansion.